Now let's talk right atrial enlargement. So enlargement, hypertrophy of the right atrium. We're still looking at the P wave, but here we have P pulmonale. Instead of P mitral with left atrial enlargement, we have P pulmonale for right atrial enlargement. And here we're looking at lead 2 and 3. P mitral, we're looking at lead 1 and 2. P pulmonale, we're looking at lead 2 and lead 3, and we're looking for a tall peaked P wave. So this P wave is going to be more than 2.5 millimeters, 2.5 small boxes tall, and this is your classic finding for right atrial enlargement. And in right atrial enlargement, we have this P pulmonale because the right atrium is the first one to depolarize, and it's just going to overpower everything. That view is going to overpower everything because we've got so much more muscle mass in the right atrium. It's going to overpower that left atrial view, and we're going to see this huge kind of big peaked teepee-shaped P wave in right atrial enlargement. Just like with left atrial enlargement, we're going to confirm this using V1. We're going to go to V1, we're going to look for that biphasic P wave again. Except this time, right atrial enlargement, we're going to see the first half, that positive half of the P wave, wider, larger than the second negative half. Because here the first half is the right atrium. That's the part that's depolarizing first, the atrium that's depolarizing first. So if we have a larger right atrium, we're going to see a larger first half of that biphasic P wave. Through a few EKGs. So first, what is our rhythm? Well, our rhythm is a sinus rhythm. Uh, Looks a little fast, but it's still a sinus rhythm. What's um, our axis? Lead 1 is upright. AVF is mostly negative, and you're like, what the is going on here? These are P waves. All these big old boys are P waves. This is a QRS complex right here. Rest are P waves. So our QRS complex mostly negative, so we are left axis deviation, and lead 2 is negative. Again, these big old boys are P waves. These are QRS complexes. Lead 2 is mostly negative, so we've got pathologic left axis deviation, so I'm thinking left anterior hemiblock. Do we have a bundle branch block? We do not. We've got narrow complexes. Do we have left ventricular hypertrophy? Well, V2 is our most negative, so let's count that out. 5, 10, 15, 17, and maybe like 19 or 20 boxes right there. V6 is our tallest, looks like, and not even 5, so we don't have left ventricular hypertrophy there. What about V3? That's pretty deep. That's pretty deep. Say 5, 10, 15, 20, 25, 30, 35, almost 35, so it doesn't quite make it. We don't have our limb lead criteria for left ventricular hypertrophy. We don't have right ventricular hypertrophy. We don't have an R to S ratio greater than 1 in V1, V2. We can move on to our atrial enlargements. And we're going to look at our P waves, lead 2, lead 3. So we don't have left atrial enlargement. We're looking for right atrial enlargement. These are definitely tall, peaked P waves. These are huge P waves. Holy mother, right? So we definitely have P pulmonale, classic finding of right atrial enlargement. Look to V1, and kind of hard to see the biphasic P waves in V1, but we have just classic P pulmonale here, so we have right atrial enlargement. Next EKG. Rhythm is a sinus rhythm. Axis lead 1 is negative, AVF is positive. We have right axis deviation. Thinking left posterior hemiblock, but we're going to keep moving on. Bundle branch blocks. Our QRS complex looks narrow, so not a bundle branch block, right or left. What about ventricular hypertrophies? Do we have left ventricular hypertrophy? We don't have any negative complexes. V1, V2. So we'll be adding V2 this like 5, 5, 8, or 9, right? Millimeter negativity to V5s, what, 5, 10, maybe like 13 or 14 right here. That's not going to get us to left ventricular hypertrophy. I don't have any complexes that are positive or negative, 45 or greater millimeters in the precordials. Lead 1 is mostly negative. We don't have to worry about that. AVL is almost all negative. Don't worry about that. AVF is at 20 millimeters or greater. So I've got 5, 10, 15, and almost like 17 or 18 millimeters. So we might be getting close to some left ventricular hypertrophy, but we're not going to diagnose it here. Right ventricular hypertrophy. We have that. So looking at V1 and V2, is there more positivity than there is negativity? There sure is. So we have right ventricular hypertrophy, which is a rule out for your left posterior hemiblock. So even though I have an S1Q3 pattern, RVH rules out your posterior hemiblock, so I'm just going to document this as right ventricular hypertrophy. Do we have any left atrial enlargement? I'm looking at lead 1 and lead 2, looking for a little notch, a little P mitral. Nope, I don't have that. So let's look at for right atrial enlargement, lead 2 and lead 3. Do in either of those leads do I have like a tall peaked P wave? And I sure do here in lead 2. Definitely have that in lead 2. We're going to confirm that in V1. Look at our biphasic P waves, and that first portion, that positive portion, is a lot bigger than that little teeny tiny negative portion. So the P wave is biphasic, but our first part, our first half, the positive half, is bigger than the second half, so we can confirm right atrial enlargement. Our third EKG, again, sinus rhythm. Axis, lead 1 is negative, AVF is positive. We've got a right axis deviation. I'm thinking left posterior hemiblock. We're going to move on to our bundle branch blocks. We do not have that because we don't have a wide QRS complex, so we can move on. What about ventricular hypertrophies? We don't have left ventricular hypertrophy. We don't have any of the complexes that meet those criteria. Right ventricular hypertrophy we do have. Look at V1. V1 is more positive than it is negative. So we're going to call right ventricular hypertrophy, and then that rules out our left posterior hemiblock, so we're just going to document it as right ventricular hypertrophy. And we're going to look for left atrial enlargement, which we don't have. I don't see any P mitral. Don't see any little notching anywhere in lead 1, lead 2. Now we're going to look at lead 2 and lead 3 for P pulmonale, peaked tall P waves, and we definitely have that in lead 2 is big old P waves. Go over to V1 and we have these biphasic P waves, and it looks like they might be pretty like equiphasic between the two. So pretty, just looking at it, looks pretty similar. But we have P pulmonale right here in lead 2, and that is a telltale classic sign of right atrial enlargement. As with your right ventricular hypertrophy, the causes of our right atrial enlargements are going to be pulmonary based, right? Because the right side of the heart pumps into the pulmonary system. So if we have issues with our pulmonary hypertension, issues with our lungs, COPD, that's going to cause extra strain on the right side of our heart and the right atrium, and it's going to cause enlargement and hypertrophy of the right atrium. So we talked about pulmonary emboli, we talked about pulmonary hypertension when we talked about ventricular hypertrophy on the right side. Same thing here with the right atrium. So pulmonary valve, tricuspid valve issues, COPD, pulmonary hypertension, it's going to put extra strain on your right atrium and cause it to hypertrophy and enlarge.